So in the chapter discussion of pediatric critical care and emergencies, the topic of discussion now will be on hypernatremia. So hypernatremia, what are the topics that we are going to discuss under this hypernatremia? So the first will be, how do you define hypernatremia? Then classification of hypernatremia based on the volume status, followed by causes of hypernatremia, clinical features, how are you going to approach, that means how are you going to diagnose, and then finally management. Okay, so we will go step by step. Before going on to the hypernatremia per se, few slides about the sodium metabolism. Okay, so sodium is quite unique because when we talk about hypernatremia or hyponatremia, it is not by the increase or decrease of sodium that the symptoms develop. It is only because of the water balance. Okay, so if it is hypernatremia, okay, there is a child who has sodium of 160, example. Okay, in that child, the volume status only will determine the clinical features. So the volume status can be hypervolemic. So much of 3% saline you are giving. So the volume status will be very high. Or if the child is having an episode of acute gastroenteritis where the child is losing so much of water, that is free water is lost. So there will be hypernatremia. So the water balance in the system only will determine the clinical features and manifestations of hypernatremia. Okay, you will get to understand this topic as and when we are discussing. Okay, I am just telling why sodium is unique here. Okay, so in the body, 40% of the sodium is present in the bone. Remaining is present in the interstitium and elsewhere. Sodium is the dominant cation of extracellular fluid. Majority of sodium is present only in the extracellular fluid, whereas potassium is mostly intracellular. So that is the contrast between sodium and potassium. Sodium is predominantly extracellular, whereas potassium is mostly intracellular. And the presence of sodium will determine the osmolality, isn't it? You know the formula for osmolality: 2 into sodium plus glucose by 18 plus urea by 2.8. 2 into sodium, say the sodium is 135. So 2 into sodium will be 270. What is our normal osmolality? It will be somewhere around 285 to 290 or 95, right? So among this 285 or 290, 270 will be sodium. So the principal determinant of osmolality is what ion? Sodium. Okay, so sodium is predominantly present in extracellular fluid and it is the principal determinant of your osmolality. So sodium rises, water will come along with it, sodium falls, then water also will get lost. Okay, so sodium will pull water wherever it goes. You can remember that, or just remember it is the principal determinant of extracellular osmolality. So predominantly you know it is extracellular, only 3% is intracellular. And why this extracellular and intracellular presence of sodium and potassium? It is because of the pump, which is your sodium potassium ATPase pump. This maintains the voltage gradient or the electrochemical gradient across the cell. And this is what I was explaining to you. Sodium is unique because the water balance inside the human body, inside our system, that will determine its concentration, not per se sodium alone.